if all goes well in terms of the resourcing, the flow of funds, and that it could be verified. I don't control the purse, but the aspiration, we have made it. 2, in terms of federal allocation for health, it's in the hands of, on me, it's also in the hands of the National Assembly, where I'm heading right now. My hope and prayer is that we will get closer, more closer to 6% than away from 6%, which will be the highest ever federal allocation in health. That I will do, yes, in terms of percentage of federal budget, because it was 3.4, literally less than 4, and we've moved it up. It's not enough, but we are working, and I know the president is intentional to increase that. We will advocate with the legislature, with our budget colleagues. This morning I did some of that work. We are now going to see in the Finance Committee how the excise can also be increased and earmarked for public health. That's where I'm heading immediately, Alifia. So I do think when we meet next year, I will say that the allocation is closer to 6 than away from it, than closer to 5. That's my promise. Now, on your side, what are you promising me? Your voice matters in achieving this as well. Your voice matters. And so raising your voice, coming out clearly, not only for federal but also state governors, look at where they are and point to them to also increase and to support this direction. If you can just use that, that's a good trade. 2 for 1. I gave you 2, you give me 1.
Thank you so very much. One thing I can assure, I'm sorry we don't have that time, but I'm sure that he has a very vibrant media section that we can continue with this. Maybe by monthly or something, we'll have to come up with something so that we can engage with him, because health investment is an imperative for development.
Yes, and Timothy,
yes,
please, there are others. So even if you can't get me, my colleague, the Minister of State, is there, the SWAP Coordination Office is there, NHIA is there, MPHCDA is there, PVAC is there, NACA is there, NAVDAC is there. They are authoritative in their own ways, and they are close to some of these peculiar issues. I sit there, maybe I'm the talking head, but you can also ask them. But beyond that, each state governor you see, whether on the road or commissioners that you ask them the way you are also asking me what's happening in their states. Sorry, commissioners, I'm putting you in trouble. But I think we've been talking among ourselves. Mm-hmm. So that it's a conversation. There is no, let's say, one solution. It's a conversation. And it is us, it's part of building that consensus. Mm-hmm. And if there are mistakes, we correct them. If there are things that we can do better, then we do them. But if we don't talk among ourselves, nothing happens. Thank you very much.
Thank you.
All right, thank you very much.
Thank you all. Please, can we just appreciate the Honorable Coordinating Minister of Health and Social Welfare, Professor Muhammad Ali Pate, CON, as he... Okay. Right. I think my work is done. Thank you.
All right, can we put our hands together one more time for the Coordinating Minister? And thank you, Auntie Moji, for that very splendid moderation. All right, you may please be seated. Now, to give a quick vote of thanks, can we welcome the Chairman of the Board of the Center for Journalism, Innovation and Development, Professor Umar Pate.
Your Excellency, the Honorable Minister, distinguished ladies and gentlemen, on behalf of the Board of CGID, the management, staff, and our partners, as well as our sponsor, we express our appreciation to all of you, specifically to the Coordinating Minister of Health, Professor Mohamed Ali Pate. We know how tight his schedules are, but he honored our invitation. When we submitted our letter of invitation, he gave an express approval, assuring us that he will be here. And we know how tight, how difficult, and how challenging the Ministry of Health is. But all the same, he has been able to squeeze the time to come to us. This is an indication of his highest level of respect for the media and Nigerians. Mr. Minister, we thank you. We appreciate all that you have been doing, and we urge you to continue to do more. On behalf of all of us, we say thank you and well done.
All right, thank you very much, Professor Pate. We would like to take a very quick photograph with the coordinating minister before he leaves. So, sir, can you please come up to the stage? Can we have the honorable commissioners from the state, the Deputy Governor Ma? Our photographers. Managing editor of Premium Times, please join us. All right. Thank you very much, Coordinating Minister. Thank you to our distinguished guests. All right. If I may please have your attention now. Hello. Are we together? Are we together? All right, so we're breaking up for tea break. We have tea break set behind the hall, and would like us to please proceed from behind the hall to have your tea break. But we will have it just a quick break for us to stretch. You may choose to take tea or take water, but we'll have about 15 minutes for a quick stretch, and we'll come back. But please let's have it right here in the hall. Thank you. And we have just 15 minutes. 15 minutes for a quick break. Thank you.
Two, three, four, five. Mic check 1, 2, 3, 4, 5, 6. Sound check. Mic check 1, 2.
Recording in progress.
Hello. Welcome back from tea break. Can we please come right back into the hall? We are way behind on time, and we have to speed up. Distinguished guests, ladies and gentlemen, I crave your indulgence, so please get settled again. Thank you. We are about to start. Please, let's get settled. Ushers, please, can you help usher our distinguished guests back into the hall? Ushers, please. I see Intiedo, an usher. I see Jude, another usher. Please help get everyone back. All right. Hello, hello, hello. Can we please get seated? We do not have all day. All right. All right. So, thank you very much. Thank you very much for your attention. We will kick off right now. And before we go right ahead, I would like to recognize the presence of the Director General of Borno State Agency for the Great Green Wall, Ambassador Usman Aliyu. Can we please put our hands together for the ambassador? thank you very much for joining us. It's a pleasure to have you. All right. So we are still here at the National Health Dialogue under the theme Evidence, Innovation, and Financing for a Healthier Nigeria. And when we talk about the problems in the healthcare sector, we understand that we need evidence, we need data, we need storytelling. And CGID Premium Times, our partners Nigeria Health Watch, and The Punch have over the past couple of years done consequential work, consequential reporting on state of the healthcare sector in Nigeria, investigative journalism, stories that show the challenges, and as well solutions journalism, that shows the solutions, the potential solutions. And today, we want to present some of these to you. And for the next session, we will hear from Punch, and it is my pleasure and my privilege to welcome to the stage Angela Onwuzo, Punch HealthWise editor. Can we put our hands together for her as she comes up to give us a reporting showcase from the Punch? Please make that round of applause louder. Thank you very much.
Thank you very much, MC. Good afternoon, distinguished guests and colleagues. Please, I humbly request your attention. My name is Angela Onwuzo. I work with the Punch newspaper. I'm the editor of Punch HealthWise. Permit me to stand on established protocols. First, I want to thank the CJID and Premium Times for inviting Punch to this National Health Dialogue. I'm here to show you some of the impact stories that we have done in Punch newspapers in recent times, actually based on the time allotted and the number of stories I was told to present. That is why you'll be having a kind of, you'll be seeing the numbers here. We have over 70 impact stories. And you agree with me that since this conversation started, we have been having two recurring words, evidence and financing. So you will see true evidence in some of the stories that I'm going to showcase here now. First of all, in Punch HealthWise, we do what is called impact journalism, where evidence drives action. Before I go to show you some of these impact stories, it will be nice to know what Punch HealthWise is all about. Of course, Punch needs no introduction. We all know Punch newspaper as a leading brand in Nigeria, and a very fearless one at that. So Punch HealthWise, Punch Health Vertical, is a project of Punch Nigeria Limited. It was primarily created to generate content to increase public awareness and knowledge on public health as contained in the SDGs. Our specific focus is on SDG 1 to 6 and then 13, with a major focus on Goal 3, which is why we are all here. Goal 3 is all about good health and well-being. If you don't have good mental health, because mental needs to be there, because the absence of mental health, it still shows that the health is incomplete. Without your mental well-being and physical well-being being intact, I don't think you'll be able to participate at this conference, and that is the whole essence why we are here. Next slide, please. So here are some of the project goals, which I told you centers on Goal 1 to 6 and 13 of the SDGs, with primary focus on good health and well-being because it affects both young and old. As I said, evidence has been recurring since we started, and then financing. Of course, innovation, which you are going to see in the stories as I showcase them. Because of time, I will not be able to go into explaining the SDG goals 1 to 6. and 13. Of course, you have them. We have 17 SDGs. But those targeted at health, environment, water and sanitation, nutrition, ending poverty, those are our primary focus. Because when we achieve this 1 to 6, in addition to healthcare financing, increasing funding for our health sector, I believe Nigeria will be above. We will stop having these worrisome global indices that keep occurring year in, year out. First is our story in Akwa Ibom State. And I remember when the editor of Premium Times did his own showcasing, he also mentioned Akwa Ibom State. And I know that if Akwa Ibom State government is there today, they will be angry at the Punch and be wondering what is going on in that state. Well, Premium Times looked at primary healthcare centers, but here we looked at the tertiary facility. And the tertiary facility here is Akwa Ibom State Specialist Hospital. Now this story, the trigger story, of course you can see the headline there. In Punch, we craft fascinating headlines. From the headline, you know the story. We don't confuse you. Looking at the headline, you will understand there is a problem with that figure. So, monument of waste. 41 billion naira Akwa Ibom Specialist Hospital with rotten facilities. When Dr. Dada presented, he talked about equipment. I won't go into that because the next story speaks more about it. So in this hospital, this facility, the governor announced that he will be establishing, Governor Omo, he will be establishing an international hospital that will become solution to Nigerian journalism. Medical tourism. The same thing happened in 2015. That is where accountability comes in, you will see in this story. In 2015, the then governor, who is now the current Senate president, Godswill Akpabio, established hospital to the tune of this 41 billion and promised the state and Nigerians that this will be a solution to Nigeria's medical tourism. So when the governor announced that, the current governor, we now asked, what is going on with this? Why not allocate such resources that you use to establish another specialist hospital into primary health care or secondary facilities? Secondary facilities are the primary health care, are the general hospitals are managed by the state. The federal government manages the tertiary hospitals and FMC. Why not channel the resources? Because we are impact-oriented and accountability-driven in Punch health-wise, we have to launch investigation. Sorry, I'm not done with the first point. Into this Akwa Ibom Specialist Hospital. Our investigation showed that this hospital was commissioned 3 days to the end of the tenure of the second term of Godswill Akpabio. He already commissioned it. Our investigation shows that this facility, 2 floors were incomplete while it was commissioned. And the oxygen plant, since its commissioning in May 2015, stopped working. Most of the facilities installed were not working. They were not functioning. And 2 of the floors were wasting away. So most of the infrastructures in these facilities were wasting away, coupled with acute shortage of manpower. In fact, the doctors there supported us in this report to the point of taking us to some of the victims of treatment failure and those that could not access facilities that died at their emergency department because they lacked basic facilities to treat them. And the few available ones are not working. He hurriedly installed them and commissioned it and left. After this story was done, the governor announced began recruitment of new doctors, because in that hospital, you don't even have, the doctors are not there. And most of the residents of the state, that's the patients, especially those that need specialist care, come with the notion that, look, this is a flagship hospital. We get our solutions there. But our findings show that some of them ended in body bags. Next story, please. Our second story is in Kogi State. Our second impact stories. Just as I told you, because of time constraints, we have about 70, but we decided to come up with these 10 because of the time we allotted, and of course, their recent publications. Our second story is on how obsolete facilities turned Kogi Federal Hospital to death house. The investigation was in two parts. It was an undercover investigation. Now, this Federal Teaching Hospital you are seeing here, it was formerly Kogi, it was formerly Federal Medical Center, Lokoja. Now, the federal government in 2023, now upgraded the facility. I don't want you to give me the answer, but when you hear the word upgrade, what comes to your mind? Of course, there should be an advancement. But the reverse was the case of this facility. FMC Lokoja was established in 1999. Our undercover investigation of this facility shows that the facilities then, that is why you see the word obsolete, are still most of the facilities they were still using, even after the upgrade. You can see accountability, we have to bring this up because it's a pure deceit. And that is where the issue of trust, the populace not trusting the government, comes in. And each time we'll be hearing, well, we should have trust in our healthcare system. With this, tell me where the trust is. So from this investigation, we find out that some of the diagnoses, Dr. Dada will, because Dr. Dada is advanced, with due respect to other medical experts here, I know when he spoke, he was talking about equipment. Now, Dr. Dada, you will agree with me that when you have wrong diagnosis, I'm not a medical doctor, you are going to have a wrong treatment. How do I mean? If you are diagnosed for malaria or typhoid, while you have cancer, what the doctor is going to treat you for is malaria. He's not going to treat you with cancer. And by the time you know what is wrong with you, it would have been too late. So because of the obsolete facilities in this hospital, there were a lot of medical errors. That was our findings. And a lot of mortality. And women were most of the casualties, especially women that needed cesarean section, women whose children, babies had distress and needed resuscitation. So after that, the House of Reps summoned the medical director, and then the hospital received the intervention. I've been warned. I've been given a time. Next is open defecation. In Lagos Motor Parks, the story is on Lagos Motor Parks, where feces became a common sight because there are no sanitary facilities. Sanitary facilities, I mean toilet facilities and all that. Even the few available ones, they were forced to pay. I know the poverty on the land, so most of them evaded the payment. Of course, anywhere they saw space and they defecated on it. So after this publication, you can see the intervention there. There was an impact. As I told you, what we do at Punch Healthwise is impact-driven journalism, giving voice to the voiceless, evidence-driving impact. Next story. So this one is in Ogun State. Ogun State community, where neighboring communities close to Benin Republic, because of this systemic failure and government failure to provide basic needs of its citizens, these people take hours to Benin Republic to go and get water supply. This story is where a story, you see a story, picture telling the story. See the situation before. That woman carrying a bath of water on her head. That was the situation before our story was published. This water you are seeing here is the source of water for drinking, cooking. Hygiene was a problem. Most of the babies that were giving birth in this community, many of them were dying because of infection. You know how important water is when providing maternal health care. I know how children are vulnerable to infection when it comes to contaminated water. You can see it, the impact after the story was done. Government agency came to their rescue and then provided them water supply. You can see the joy there and how this story relieved the plight of the people in those communities. Next, please. Yes, this fifth one is fake and unregistered asthma inhaler. In 2023, JSK exited the country because you know how our country is. I don't want to go into that. My MD is here, though represented by our deputy weekend titles editor, but I don't have the capacity to begin to speak on government failure and issues, so I will go straight to the point. There would have been some statement I would have made. So, but this is a total regulatory failure. You all know why JSK exited the country, and they are major suppliers and providers of inhalers for those that have asthma and respiratory conditions. So what happened? Because of our weak regulatory system, after their exit, immediately, we call them merchants of death in health in Punch. Merchants of death, those that produce drugs under the bridge of Idumotas and Onitsha. What did they do? They went and started importing fake inhalers. You can see the color. Looking at the color, you know the one that is original there and the one that was fake. NAFDAC commended Punch and said, thank you for bringing this to our notice. And of course, they waded into this situation. There was intervention. And you know how vulnerable people that have asthma is. Coupled with, what is it called? Fake drugs. You can imagine the level of crisis they will experience. People that are already faced with a crisis. Both in terms of cost, because after that exit too, asthma drugs became very, very expensive. Now buying an inhaler that you are buying 5,000 before for 40,000, at the end of the day, it's fake. Also now choking you to death. So our story brought our intervention. So Lagos, the seventh story here is, our stories are very inclusive. When I say inclusive, in the sense that those living with disabilities, we also try to cover them. These are our para-athletes in Lagos State. Some of them have won, that is those living with disabilities in Lagos State, but found career in sporting. Some of them have even won international trophies. But it was so disheartening, I don't want to use the word disgraceful, that they were owed 19 months allowance. Some of them under the bridge of Ojo Elegba, and then that stadium. I think, what's the name? I want to remember the stadium again. National Stadium, Surulere. They turned to beggars. Some of them were bedridden. In fact, Mr. Akoshile, I think he's chief press secretary to the governor of Lagos State. He told me the governor's concern about this and was really bitter because he never knew they were going through this. And after that, less than 1 week, all of them were paid. And I want to let you know that this impact you are seeing, we're not even the ones that track the impact. The beneficiaries, they are the ones calling us, expressing their joy.
So sad.
That is what evidence can do.
So sad. So sad.
So, lastly,
so sad. Can we put our hands together for Punch? Can we put our hands together?
1 minute. Okay, so the 10th one is harvest of death. Here, because we cannot finish I cannot finish my presentation without looking at maternal and child health. No. So here in Ogu community, there was no health facility in that particular community, and women were delivering at home. Maternal mortality and infant death were so alarming. And after our story, there was an intervention. Now let me tell you the reward.
Can we put our hands together for Punch? Can we put our hands together? Keep clapping, keep clapping, keep clapping.
Clap for our
keep
award.
Clapping.
As you clap for our
Such
award.
brilliant
You cannot hide
journalism.
this award. Look at our awards. Even the Dame 2025, Punch Healthwise won the health category. Yesterday, CJID can bear me witness, Healthwise also won your health category award. But because I've already sent the presentation, I was not able to include it here. You can see what is called evidence-based impact.
Thank you
very
very much.
Thank you for your time.
Thank you very much. Like I said, when it comes to evidence, we're doing a lot of work. There's a lot of work that is being done. Thank you very much, Punch, for that presentation. Now, in the spirit of keeping this interactive, I want to take one reflection. So from all she's presented, any reflection, thoughts, comments? Okay, I have one. In 1 minute. No, 30 seconds.
Good afternoon, everyone. My name is Bishop Akin Thomas, and my reflection from this has been that the moment you report the bad news, it was not to shine light on bad news, but to bring out a solution. And for every trigger headline that was shared, there was a solution to back it up. So I think that's very good from journalists to not just spread quote and unquote bad information, but to push it so a solution can come out of it. Thank you.
All right. I saw one hand here, so I'll just take it.
Thank you very much. My comment is just two. Number one, I will commend Punch for doing what they did, even as most of their issues were done in southern Nigeria. States like Jigawa were not reported. No state from the northwest or northeast. Second, I think I will have to commend the professor because I've seen some things coming up. You cannot say maternal mortality here because you get results of maternal mortality in a survey. You just don't count death in the hospital and call it maternal mortality. So that means there is a big knowledge gap for our colleagues in the journalist profession when they are trying to report on health. So please, I will draw the attention of anybody who wants to talk. Any maternal mortality, child mortality under 5 are rates, ratios, and proportions that you get from survey, not from hospital. They are gotten from the population. So whatever you see in the hospital is not maternal mortality, it's maternal death. Anything you see in the hospital is child death, not child mortality. Thank you very much.
Thank you very much for that reflection. I wonder if Punch thinks otherwise, or if another story will be shared, but we'll see. Okay, hold on, I'll give you the mic. Okay, all right. So, hold your thoughts. We're still going to have the commissioners come on, and you will have the chance to interact. Are we good? Are we good? All right. So now, our next session. Hello, everyone. Can I please have your attention? Thank you. So for our next session, like we've said, evidence, innovation, all of this require political will. We need leaders who can make tough decisions. We need leaders who can budget for health. We need leaders who can create accountability structures. And we have those leaders in the house today. And they're going to be telling us about their priorities for the next year with regards to health. Can we put our hands together for the honorable commissioners that we have in the house? Come on, can we make it better? All right. So we will have the commissioners come up for 7-minute presentations each, where they would provide their priorities for the next year. And we will go right ahead to start with the Commissioner for Health from Katsina State, Honorable Musa Adamu Funtua. Can you put your hands together?
Gentlemen, let me seize the opportunity to commend the CGID and Russia to stand on the existing protocol. Well, I'm here as a privilege given to me as a supervisor officer in charge of health to speak on behalf on issue of Katsina. When you are talking Katsina, yes, regard health sector, Katsina, you are talking about the Dukwarada. That is the governor. At the same time, this is a kind of, let me introduce Katsina itself. Katsina is a state with over a population of 10 million. It has 34 local government, 361 wards. At the same time, it has the largest health facilities across the nation with 1,702. 1,702 before the comment of this administration. At the same time, we operate based on tertiary, secondary, and primary health sector. In view of that, the government believes in building a future. A building on future, the main thing building about that is about the no important asset than a human being. Human being, when you are talking about situation warrant, we have to say security first. Education, by the nature of the environment in Katsina, we have all year round farming activity in order to no country or a state can boast of say that we are on our, if it has no solution to the social problem, that food security. And when we are talking about the human being and about the health, health is wealth, wealth is life. And the issue of health is simply, you cannot divide a road. You shall either face it or it shall face you. So in view of that, the cardinal objective and the focal policy of the government believe in continuity, that all the inherited project, we must complete it. And we believe in train and return and building a human being. But let me take it in my own stand as a supervising officer. Yearly on that review, this is a state implement a 7% budgetary, both recurrent and capital expenditure yearly on that review. Well, justification, we take it, we have the category of building a human being. At the same time, we believe in partnership, collaboration, and teamwork. And with this kind of government that we take everything directly to the door of the common man. That's by engaging community development committee and the people-oriented project. Even our budgetary provision came directly based on the desire and the people need. At the same time, when the government come on board, it decides, okay, problem identification is a solution to a problem. That's why we have 361 wards with all the kind of 1,700 facility. We decided, okay, let's go to have effective comprehensive primary health care. That means the problem is being identified. That's the process that you can drive in. So in view of that, we go into embark a serious project of primary health care. We decided out of that 361 wards, we are going to have comprehensive and effective primary health center with a human resource, with the infrastructure, and all the basics and needs. Particularly that everybody knows that there is a shortage of human resource in terms of medical workers in every sector, but in view especially doctors. So in view of that, in order to enhance the mixture, today, as I'm speaking to you, we have 261 comprehensive health center fully completed, 100%, and with the employment of workers, 100% based on the need of the local, based on the need. And we are targeting, based on yearly on that review, we are targeting the balance of 100, so that the roadmap completes with 361 wards. In the tertiary sector, and at the same time, there are most of we believe in the kind of objectives, particularly in partnership and collaboration with the development partners. Our approach is sector-wide approach, which is the basic reality that where how we build our budget of people, which we take it directly to the common man, based on the interest and desire of the need. We have 15 period constituency. As I'm talking to you, each and every period constituency, when the admission comes on board, it has 21 general hospitals. Today, we have 29. Each and every period constituency has a 15 standard general hospital that duly completed by this administration. When we go into tertiary, today we have existing of world standard dialysis center, 100% completion, being declared, launched by the Mr. President when he's in order. And at the same time, we go into PPP that are managing for the issue of dialysis. And we have a medical pharmaceutical company, a contract of more than 12 billion naira with a large product. And today, all the machines and equipment are very much on ground. At the same time, the balance of it is about 91% completion due to some observation and correction. As I'm talking to you, we have a medical tourist center, Katsina State Medical Imaging Center, in collaboration. It's a project that costs the billions of naira with all the, most of the activities and facilities or equipment. It's not a window shopping. You have to collaborate, you go and see them, then you buy the routine. But let me make it clear for you. All the equipment that we are worth them for 2 billion naira, they are 100% being paid, and more than 90% are very much ground in Katsina State. All that in the structure and the collaboration. So, gentlemen, in building the human resources, we have, our doctors has a future. We have residency training 100% completed, and now it's existing. And we have currently, as I'm talking to you, based on the primary health center, recruitment is going on. is going on. And we have the approval for replacement. As today, if somebody retire, tomorrow or somebody there, we replace him immediately. At the same time, currently, we open it based, we go for competition. We open the competition in order to get the appointment based on merit. Everybody has a right to it. Yearly on there, we approve 788. Forget about it, revelation or collaboration of primary center. As I'm currently talking to you, on the primary center, we are recruiting 533 people that we want the basic in order to enhance the new primary health centers. At the same time, in collaboration with the OSING, all this kind of program going on, particularly when I'm talking about issue of 261 comprehensive center on ground. We have 261 KKNFF tricycle ambulance very much on ground. And we have, even last week, we have 15 number of modern gadget, highly acceptable ambulance very much on ground. And we are targeting to have 27. So gentlemen, when I'm telling you about Katsina State, we believe in human resource development, we believe in train and retrain. As I'm talking to you, we have the younger ones currently in Egypt, in China and Germany that employ based on the performance coming from the community, for public higher institution to go in order to undertake a medical course, so that directly we source from the community, we go to the community with everyone. And currently, what we are doing, we believe in train and retrain, which has become an order of the day in order to enhance the capacity. Because without a proper comprehensive building, without a human being that can manage the thing, is another sector. So gentlemen, Katsina State is on the right course. Dr. Dukwaroda is working. Each and every, when you identify a problem, you must have a driver or a captain that can navigate, or a pilot. Currently, as I shot it, I feel each and every project that we inherit, we 100% completed. And when the one that we have planned, we are on board. Secondly, we have the coming year budget this year, based on the community needs and desire of the people. Most of the community are there in need of help. So we make our budget and provision based on the people need, which is about 15%. Abuja Declaration. So in view of that, both the health sector, tertiary, secondary, and primary center, the system is working. So we are concerned, most of the people that we cannot count ourselves with the issue of insecurity. But today, we checkmate it out, we engage, we identify the following, we arrange the courses. As I'm always standing here to say that it's a kind of well-planned and designed crime. But today, we have no permanent bandit come our state. And only the 3 local government bordering with other things that we have a switch attack. They hit and run. And most of them based on the pressure of community engagement and community development, particularly with the DUCO army on ground that we trained as a criminal as a son of the soil, they are coming out for negotiating. Because most of them, we know them, they know them, they are monsters. They are not monsters. They came out for negotiating and engaging, which is the object and the kind of objection of the administration of the DUCO Umarda. He didn't believe in negotiating with the criminals. But when you surrender, you keep at ground, you are ready to come and back board into your family. So gentlemen, Katsina State, under the health sector, with tertiary institutions, best human resources, infrastructural activities, we achieved 87% implementation of our budget. And most of the rollover programs that are going, we are on course, and we have the money on ground. And coming in, let me make categorically make clear, no contractor, as I public servant, or else a single cover in Katsina State. So gentlemen, Katsina State on the right course, Katsina State in collaboration, Katsina State in teamwork, Katsina State in belief in value of human being, train and retrain. So as far as you are concerned, this is a little bit about Katsina. And by those, I will have, but cut me anywhere. Seeing is believing. What I'm saying, a day or a night, whenever you come, you see the reality. We are gathered here in the presence of journalists. And we know journalists that we have an ethic. So gentlemen, our doors are always open. The President Corona is always ready for you. When you come here, let's even discuss the commissioner. The journalist we have always is a friendly doctor, which he believes one-on-one. So our system is working. At the same time, we are really compression, and we are ready to partnership, we are ready to collaborate. We believe in teamwork in order to bring good governance and well-being of our people. This is our plan.
All right, thank you very much, Honorable Commissioner. Can we put our hands together for him? All right. So the idea of this is for the commissioners to present their priorities for the next year, to give us commitments, actionable commitments that we can track and we can follow through it. So I hope that you're taking notes. We'll provide an opportunity with all of them on stage for you to ask questions and also, for you to press further. But we're trying to manage time and schedules. We know we are way behind on time. So we'll be breaking up the commitment session to take our very first panel, the real cost of primary health care, examining the state of PHC delivery in the subnational level. And after that, we'll continue with the agenda as planned. So to moderate this panel, welcome with me Tolulope Aderelu Balogun from News Central TV. Can we put our hands together for her? Please keep it coming, keep it coming, keep it coming.
Good afternoon, everyone. I know it's been a long day, and this is a health conference, so I think what we'll do is let's just have everybody stand on their feet and follow me and just do a few stretches. If we're talking health, the National Health Dialogue, I would like to keep my audience healthy as well. So please, let's stand up. It's been long, and you've just had tea. I can't have anybody falling asleep on me. Thank you so much, sir. So now if I see anybody or hear any snoring, I know where to look. Good afternoon again, ladies and gentlemen, and thank you so much for your attention today. And thank you also for your presence. This is a very important conversation, and I'm going to call up my guest. I think we might need an extra chair up here, just to be sure that we fit everybody on the, on this podium. So, first off, joining me, we have the Executive Secretary for the Kwara State PHCD, Professor Nusirat Elelu. Please, a round of applause. Let's keep the applause going, please. Then we also have the Editor-in-Chief, African Journal of Health Economics, Professor Obinna Onwujekwe. Please, a round of applause for him as he makes his way to the stage. We also have the Health Editor for Premium Times, Nike Adebowale. Please, a round of applause for her. All right, today the first two guests are joining us virtually. Nika just joined me on stage. Then we also have Dr. Ibrahim. We also have Dr. Ibrahim Wada, the CEO of Nisa Premier Hospital. Please, a round of applause for him. And rounding out those panelists who are on the stage with me, we have Professor Bello Jamal. He's the Executive Secretary, Kaduna State Primary Health Care Ward. Please, a round of applause for him as he comes to the stage. So just before we get started, I want to ask a question of the audience. How many people here in the last 1 year have either visited a primary health care center or know someone who has? Just show by your hands. You visited a primary health care center or you know someone who has? That is a very small number of hands in this audience. And I think it's something we need to take note of because primary health care centers are meant to be the very first line of medical defense. So let me also ask one other question. Who would choose a PHC near them as their first point of call for a non-life-threatening situation? By a show of hands, who would choose a PHC around them if it was a non-life-threatening situation? Raise your hands. Again, a very small number. And I think it's one of the things that it shows us is the lack of trust that exists for many people when it comes to primary healthcare centers. So just an establishment of the conversation we're going to have, and we will have an opportunity to take questions from the audience today. So this critical discussion is one that is on the real cost of primary healthcare in Nigeria. And our focus today is on understanding the current state of primary healthcare service delivery at the sub-national level. And as we all know, primary healthcare is the backbone of any effective health system. Yet across Nigeria, there are persistent challenges in ensuring that services are accessible, reliable, and affordable. So let's examine what it takes to deliver quality care, from funding and staffing to infrastructure and operational efficiency. So once again, thank you to my panelists here, and also thank you to the panelists joining us online. So I'm going to go first to the Executive Secretary of the Kwara State's PHCDA, Dr. Elelu, who is joining us virtually. Let's look at subnationals, and of course we know they're the closest ones to the communities. From your experience, what governance reforms are most urgent to strengthen PHC delivery at the states and LGA levels? I do hope that Dr. Elelu is online with us. Okay. Hopefully we'll be able to get her back to join the conversation. But I'll have that question also go to Professor Jama as well. So looking at the subnationals and looking at service delivery, particularly for PHCs at that level, what are the governance reforms that you think are most urgent in order for us to strengthen our PHC delivery at the states and LGA levels?
Okay. Thank you so much. Good afternoon. No doubt there are a number of key areas that are critical, that are required to deliver quality primary health care service delivery in the country, from infrastructure of the facilities, to human resources for health, to supplies of commodities and equipment. But having asked of the most urgent, I think I would say, as a reflex, that it is human resources for health. Human resources for health, I think that's is the most urgent. The staff workforce are intelligent. Whatever renovation one would have made in the PHCs, whatever equipment would have been supplied, it is the workforce, human, that would operate them. And I think we are seriously lacking in that area. So most urgently, I think, is human resources for health. Now, what has been done in Kaduna State as a prototype subnational in human resources for health is the first identification of the gap. Gap analysis and needs assessment have been conducted over the last 2 years. And from what is on ground in terms of the number, we had only 5,000 staff to man 1,136 PHCs. And this is against the 15,000 plus that has been prescribed by the minimum service package. So that's a gap of more than 10. So we had requested to His Excellency to approve the enrollment of 1,000 staff annually to fill that gap. But that would take 10 years. 10 years, if one is successful. Annual recruitment of 1,000 staff would take 10 years. And that's more than the 2-year period that an administration would have. So what we had as a correction was to have an approval to recruit 1,800 for the next 4 years. And that has been done. And 1st December 2020, next week, virtually, they will all would have been at their various stations of service. And it's not only to recruit them, to also have prompt replacement of the existing staff due to statutory retirement or death or whatever reason. So this has been there. It's not only to have them in number, but it's also to distribute them equitably. You could have some PHCs having perhaps 8, 9, 10 midwives, and another is having 0 or 1, struggling. So there's no that equity in distribution. So still under that umbrella of human resources or health address, you have to distribute them equitably. And then to train and retrain them, both in the technical aspect, the requisite knowledge they're required to deliver the services, and also on moral grounds. Absenteeism, truancy, late coming, how to talk to patients and patient relatives. We have already this bad reputation as public hospitals or facilities to speak harshly to to patients and patient relations. I think somebody has mentioned that this morning.
Yes.
So we also address, because we have found out that that is an important deterrent to people coming to public space. They would rather go to traditional alternatives where they are being treated with dignity. Okay, so it's a large spectrum under human resources for health to have them in the right number, to have them the right distribution, to also have them trained in some
basically giving healthcare workers customer service training.
That's right, yes.
Basically.
And all these things will have to be tracked, and that is been done. So in summary, I think human resources for health is what we seriously lack and like at the same time. So if it's something to be done urgently, I think it's in the same line, and some of the states have heard of. Katsina State is also doing that.
Yes.
But so this is what is should be done, I think, at subnational levels. Thank you.
Thank you so much. And I'll bring Professor Elelu back in because it's still the same question. And just to, again, domesticate this conversation, I like the fact that we've heard a lot of data and numbers today, but we also need to realize that behind those numbers are families, are mothers, daughters, sisters, wives, families that are broken apart and are suffering loss because of the failure of our public healthcare system, particularly at the primary level. So according to recent data, over 16,000 doctors and over 75,000 nurses and midwives have left Nigeria in the past several years. So you have states basically trying to fight for the number of healthcare workers that are left and trying to urge associations or councils like the Medical and Dental Council of Nigeria to, in a way, fast-track the graduation of those who are available, and we're still running into issues with that. Professor Lelu, let me ask you about what's happening in Kwara State in terms of the urgent reforms. We've heard about infrastructure being an urgent reform as well as human resources. What's the Kwara story in terms of what you think needs to be done to strengthen the PHCs?
Thank you very much. Sorry, I had a poor network earlier, but I think it's better now. I hope you can hear me.
Yes, we can.
Thank you so much. Yeah. So just like my colleague has said, pretty much infrastructure, human resource for health are very critical ingredients when we talk about the first point of health system in the country, the way the health system is steered. And it's really say people to raise their hands. Although I'm not in the room, but we don't have that many hands, coming up in terms of patronage of our PHC. But having said that, for Kwara State, we are doing a whole lot in terms of infrastructure revitalization in the country. Kwara State also keys into that model. We know that the infrastructure, I always tell people that, I always have this application, come and set up a primary health care center in my village, in my settlements. Every day I have these applications coming in from community settlements and villages. And I say, yes, is actually setting up the PHC infrastructure. The most difficult is actually the human resource for health. What's the building without the people that are actually going to provide those services in the states? And so for us, in the state, we're prioritizing the existing primary healthcare centers that we have and ensuring that we bring at least one functional primary healthcare center to a level 2 within all of our 193, apex wards in the state. For Kwara State, we have, 16 local governments and 193 wards. And as we speak, we have functional primary healthcare within those facilities that we have moved onto level 2 PHC to ensure that we have a full complement of services where we have assessment. We did a baseline to see what are the existing human resource for health. The JAPA syndrome is a national issue, it's not a Kwara issue. Several states are battling with human. And at the end of this baseline assessment that we did, we actually had a recruitment plan for the next 4 years. And every year we are going to be recruiting over 1,000 people. And I'm glad that for this year, the governor approved last year, October, for us to recruit 1,005 health workers into our civil service in the states. And for now, we already have those 1,005 within the civil service into the primary healthcare space in the state. That has improved the quality and quantity of the people that we have. But of course, the problem still persists. We still have people in terms of equitable distribution of staff. People naturally do not want to go to, hard-to-reach settlements, security compromise settlements. So we are now trying to look at having situation whereby we're having performance for results, encouraging people to run shifts, whereby we have additional, funding provided as incentive for our health workers to also run those 3 shifts. That is usually a challenge in hard-to-reach settlements in the state. Okay. Finally, we also do a lot of capacity building, training and retraining of our health workers to ensure that, look, you are in term with some people have graduated over the last 10, 20 years and have not gone through so many new training. So what we do is to do a lot of capacity building in terms of basic emergencies, life-saving skills, and etc., to ensure that we have quality service delivery in our system. Thank you.
Thank you very much for that. And so we've heard from Kaduna and Kwara that there is a staffing issue, there is allocation issues, and then there's also, of course, training issues. And I want to come to Professor Onwojekwe now. We know that many public primary healthcare centers exist on paper or are only non-functional. And that documentary that we saw earlier was, I think for many people, it was very, very hard-hitting, the state of many primary healthcare centers across the country. What does the current evidence reveal about the real financial cost of weak public healthcare systems for Nigerian households? All right, we're having some technical issues with him, and I hope that we'll be able to connect with him very shortly. But I'll go to Dr. Ibrahim Wada, and we've seen a lot of people shifting their attention from public facilities to private facilities. And some would say there are situations in which those who are meant to be working in the public facilities direct traffic, direct patients to even their private companies or businesses. And so there's an increasing role for the private sector to play in healthcare delivery in Nigeria. So how can public-private collaboration help improve the qualities of the quality of the PHC and even the continuity of care?
Thank you. First, I must appreciate the CJID, Premium Times, the Nigeria Health Watch for this, I think, mind-blowing effort to get accounting officers from the states and the federal government here and devoting your time to address one of the most critical issues of our time. Critical in the sense that nothing about health indices favors Nigeria. However, the reason I'm here to talk is not to complain, but to tell you that our cup is half full instead of half empty. In other words, there is some hope on the horizon. You are looking for solutions. You are also looking for practical evidence. 70% or so of our nationals, our citizens, when they wake up and there's a problem with them, apart from paying out of pocket that we say, they are also being treated in private centers of different grades. So private medical practice, which was nearly zero at the time I became a doctor in 1980, is 70%. And you worry, public hospitals should be the ideal. Why? Because it's cheaper, and, etc. Whether or not the statistics is clear, what is happening, especially in urban centers, is private healthcare is growing and getting bigger, innovative at the same time. I have tasted public-private partnership. What does that mean? A public hospital, the Garki Hospital, that was run publicly for like 20 years. It was the first hospital in the FCT. And after 20 years, they really had to close it because nothing was working well. They tried to renovate it, but it was very challenging. So they offered it as an experimental PPP, a government hospital big size, more than 100 beds, had really ruled the FCDA health scenario for a long time, grounded. We were lucky in a way that we were selected. I gave a talk recently in a very transparent manner and challenged. Turn this, not so nice general hospital to a model, standard secondary and tertiary facility. History has shown us that in terms of facility maintenance, in terms of doctoring, in terms of results, this is far above what I had experienced in a public sector, totally public sector run place. So NISA Premier had shown the country that a public hospital can be well run by Nigerians. I did not bring foreigners to help. It's 18 years since we've been running that hospital now. Instead of being downtrodden, for example, like some of the facilities we saw, and some of the existing public general hospitals, Garki became a beautiful bride to the extent there was an effort to push us out, I think 2 years or so ago, before this new administration saw the benefit. So it's a progressive center where people who are sick, to me, if you are sick, the environment you should be treated should be as good as Hilton Hotel. It should not. Thank you. That is your time of need. And do you people know? Some people don't go back home from there. That's their last port of call on earth. What business do we have to take them to dilapidated places? Is that how we want them to say bye-bye to this world? Some of them? So PPP at the general hospital level has succeeded. I am almost certain that we Nigerians as a people, like the minister was telling us, we must hold our destiny in our hands in a way that we contribute to a better healthcare. You from the media will be saying the cup is half full, not half empty. Then can this be descended to the primary healthcare level? That should be the question on anyone's mind. You want my answer?
Wait, Dr. Wada, no, Dr. Wada, hold the answer, because I'm actually coming to that question, and I think it should be part of the solutions we talk about before we wrap this conversation. Just hold on to that.
Thanks. Okay, thank you.
Thank you so much. Nike, let me bring you in. We saw what the Punch presented to us in terms of the trigger stories and then the consequences of that, how public attention and public outcry can come to bear on certain situations. And investigative journalism has revealed major gaps, deficiencies in our primary healthcare structure in terms of infrastructure, staffing, service delivery. Where is the media? How can the media continue to expose these weaknesses while also protecting sources? Because sometimes the information comes from whistleblowers. It comes from people who want to remain anonymous, who have the information from behind the scenes, and then make sure that we continue to shine a spotlight on this healthcare situation.
Okay. Thank you so much for that question. Okay. Is it okay? Okay. As health journalist, I will be speaking from my own experience. As health journalists, we're meant to actually work on stories, work on reports that actually exposes systemic gaps in primary health care. I mean, primary health care is like the bedrock of any strong healthcare system in any country. Oh, sorry. Can you hear me? Okay.
They want to see your audio.
Okay, so PHC is the bedrock of any strong health system in the country, and at Premium Times we know that, and that's been the core of our own reporting. So for journalists or for media to actually protect their sources while also getting their stories out, I think it's almost impossible, I must say, because we watched the documentary here and we saw faces of people that have been affected and still being affected by the poor healthcare system, especially in the rural communities. If you had not seen those faces on the screen, if we had just narrated, maybe like audio and all of that, you feel the impact, but not as much as you'd feel when you saw the video. I mean, everybody here watched the documentary and you just felt this kind of pity, like there are actually people going through this. I mean, we're seated here, like Vivian said earlier, in a space fully air-conditioned and all of that, talking about health. But you really need to go to the rural communities to see those that are really affected by this. People are really going through a lot. Like some of the investigative reports that Premium Times has done, you see people that lost their lives, their kids, like then your pregnancy halfway. There are some people with postpartum hemorrhage, just a lot of stuff that you won't see happening. I mean, well, yeah, sometimes we go to the health facility or the hospital and maybe there's just a little queue. We'll be complaining that, okay, the queue is too long and all of that. But if you go to the rural communities, they will wish that they actually have a PHC to visit and just a little queue for them. They do not even have a PHC to visit. Like, is it possible for people in rural communities to just stay and sleep well without the fear that if something happens, which health center would I be visiting? So for media and for journalists, for us to actually bridge this gap and keep reporting while also protecting our sources, what we can do is grant them anonymity. And this is what we do in Premium Times, and majority of the news outlets in Nigeria actually, they protect their sources. But again, that is kind of tricky because there are some of these sources, they'll tell you that I do not want to be anonymous. Put my face out there. What do you do in that kind of situation? I'm not sure, but I'll get back to that later. So we just go under anonymity. In some of the stories Premium Times have published, please, you see that we mention names of some persons, but would reiterate that some of these persons don't want their name to be mentioned. Especially when it comes to health workers, you're really scared of speaking with journalists because you're scared that after the report comes out, they may lose their jobs. You know how it is in Nigeria and all of that, so they're scared of speaking with journalists. So in cases like that, we just like, okay, just give us the information we need to know, and we'll just say a particular health worker in a particular place. There's a story that we also did on tuberculosis recently. I think I actually did that story. When it comes to taking pictures of the sources and all of that, we use their back sometimes or the side of their face just to protect them and let them know that, see, you're safe. We just need to put this information out there. I mean, we're working together. We're trying to get better healthcare for everyone. That's what we're doing. But again, if we're trying to take the sources out and all of that, we can actually rely on documents. There are some really strong documents in Nigeria, like the NDHS reports. It comes out, I think, every 4 or 5 years that we can actually rely on. But it is not enough. Again, we can use pictures as evidence to back this story. Again, referring to my the documentary that we watched earlier, you see that some of these places, we just showed you pictures to see the dilapidated state that they are in. And the pictures tells a lot of story. So instead of, if you say that your source is kind of like at risk, if you put their faces out there or put their names out there and all of that, you can actually rely on the pictures. Go to the field, get these pictures, get these videos, and tell your stories, just like in a documentary format or in a writer format. Then I noticed that in your question, you only asked of the safety of sources. You didn't actually talk about journalists, because we actually need this safety. So you know what has been happening. I can't really say much about that, but journalist safety also matters. So at Premium Times, what we do is, if you're going to the field to work on a particular story, and either we sense it as a dangerous trip or not, you must let the office know that you're going on this trip. And yes, you need to check in. You must let the office know that you're going on this trip. So if we don't hear from you within 12 or 24 hours, we know what to do. And so like, where's Nike? Where's this person? We're not hearing from her. And she went to Akwa Ibom to work on this story. We'll be able to know what to do at a particular time and all of that. Sources, journalist safety also matters. Then I also think to protect journalists, aside what we do at Premium Times, it's important to kind of like build maybe a cross-newsroom coalition, if I must say, like a collaboration. I always say collaboration is always more impactful over competition. If we can come together and work on a particular investigative piece, it will be more impactful, and it will also save your reporter from any risk attached to that particular report. I'll give example of the Panama Papers. Sorry, I'll take a long. I'll give example of the Panama Papers. I'm sure some persons here might know about it. A group of journalists or group of media houses actually came together to work on some leaked documents. That was like a few years ago, I think, under the International Consortium of Investigative Journalists. I think Premium Times is the only Nigerian newspaper amongst those people, actually. So they came together to work on very impactful investigative reports that some heads of country and all of that actually resigned after that particular report. So where am I heading to with that is that if those documents, because the kind of people that the document revealed some secrets they do not want people to know about, they're really powerful people. So for instance, if I had written that story alone as Nikki Adebowale, I'm at risk. They will find me because it was really that terrible. They will look for me anywhere. But with that story, some of the bylines, you see stuff like Premium Times, you see stuff like Panama Papers. So let's assume we did the story, Premium Times, Washington DC, AP News, The Punch, Nigeria Hot Watch, NAN, and all of that. We did all of the stories together. So if you want to pick a particular person, you're targeting a particular journalist. So are you going to target the entire Premium Times or the entire NAN or the organizations that came together to actually do that kind of report? No. So I'm saying that it's better for newsroom to actually collaborate, to also as a way of protecting their journalists, because I believe that a shared risk is low risk, or I say a shared risk is no risk at all, or reduced risk. Yeah.
Thank you so much.
Question?
Yes.
Thank you.
So I want to go back to Professor Jamal, and let's also continue the look on the primary healthcare centers, but also political priorities. We are a very political country, and Nigerians understand what I mean by that. It feels like oftentimes decisions are not made necessarily in the best interest of the people, but in the best interest of political. I'm looking for a word here. Of political situations, let's just leave it at that. And so when it comes to primary healthcare centers, it feels like those decisions are then life and death for the average Nigerian. And I want to know how states or how people in positions of authority like yourselves in this kind of situation can balance political priorities with the technical needs to ensure consistent funding and long-term planning for PHC systems. Nigerians want to believe that government is a continuum, whether at the federal level, the state level, or the local government level. But oftentimes it seems once an election comes, priorities change, goals change. Somehow the finish line gets moved because it's another person in place. How do we continue the momentum that seems some states are now sustaining?
Thank you so much. So I think this is an important question. When I came in this is personal now, as the ES, I thought, and in political dispensation, I thought 90% of the job would be technical, purely, only 10% will be political. But as the days rolled by, one came to understand that actually the political component of it is actually more than 10%. So there had to be some rearrangement. But overall, as a state, I think the way to make the balance, the safest way, is to look at them distinct. This is purely political, this is technical, recognizing only the point where the two intersect. And that point of intersection is not less important than either the standalone political or the standalone technical. But I think if there is this plan initially to say, okay, this is purely political aspect, but this is the technical aspect, I think one is safe just to address the intersection. What does that mean? The sustainability now of the PHC systems. And the reality is that we have tight physical space. The foreign donation is dwindling. So the government, I think, to have this sustainability now, I think it's a complex question. I'm looking at the sustainability aspect now. It is to look at a way of sustainable funding, and two, to make this planning realistic, looking at the reality, and then to prioritize. Prioritize what activities should be there. And then to use the data that are original, not to go somewhere abstract, maybe some random website, and then imbibe their submission and apply it locally. What we have done in the state, in Kaduna State, for example, have you realized the tightness of the physical space? We were deliberate, looked at only those areas that are looking at us sternly in the face. And we came with an agenda, we call it 2+2 agenda. 2 major goals and 2 minor goals. The 2 major, number 1 is to have a reduction in maternal mortality. This is a national thing. Okay, it's not just only to say reduction in maternal mortality. We went to put in some figures to that. whatever you put some numbers becomes more beautiful. So we had some assumptions and comparisons with other states in the nation and then with other African countries with similar demographics and GDP as Nigeria. So we now said we want to have a 25% reduction in maternal mortality over the first 2 years of this government, 25%, and another 20% reduction over the subsequent 2 years. This is for maternal mortality. It's for childhood mortality, and by childhood we meant the infant mortality, the neonatal mortality, the under 5 mortality combined, to have a 30% reduction over the first 2 years and a 25% reduction on the residual burden, having removed the first 30% over the subsequent 2 years. So for maternal mortality, 25%, 20%. For childhood, 30, 25%. If I'm to oversimplify, for example, we say, okay, maternal mortality 800 per 100,000 per year. So you want to reduce it down to 600 realistically. So from 800 to 600, you have 200. Over 800, the emission, that's a quarter now. So that's how we got the 25%. It's oversimplification, for example. So these are the two majors. The two minors, one, to have an enhancement in female reproductive health, including family planning, because an average woman in Kaduna State has a fertility rate, profits here, 5.8%. I think that's massive, 5.8%. So for the most important strategy here is to reduce the birth rate. That's a simple strategy to address the maternal mortality. So first minor, enhancement in female reproductive health, including family planning, and we felt is going to help us achieve the first major. And the second minor is to have increased penetration or acceptance of vaccines in the community, because predominantly the childhood killer diseases are vaccine preventable. Sadly, we have lots of local government areas and communities as 0 dose. So we want to enhance that acceptance of vaccine that will eventually reduce the childhood mortality, which we believe is going to help us attain the second minor. So this is an initiative that is realistic, that has been prioritized, and we're looking at that. 29th May this year marks the end of the first 2 years.
So I apologize for interrupting you, because my brain is just asking how. Because it's one thing to set the goals, it's one thing to set the timelines, but you need to answer the how. Unfortunately, we don't have time. We've shortened this session because it has been quite a day for everybody, but they have told me that I have room for 3 questions. Okay, they're saying 2. It's not my decision. We have time for 2 questions. So the first 2 hands that I see go up for anyone on the panel on this side. I've closed out. Let's start at the back, please. Okay, sorry. Please, you've asked a question. I apologize. Let me have somebody who has not asked a question so we can make sure it's gone around. Have you asked? Okay, you've spoken today. She has not. But you spoke earlier, right? Okay. So I'll start here, and then the gentleman in the back, please. Can we get... I said the first 2 I saw. Unfortunately, my direction was in my eyesight was in this direction. I apologize. Please point at him. Oh, he's the one. Please, let's start with her. Go to the gentleman in the back, and I'll beg you for 1. The lady who was standing. 1. Thank you. Please, very quickly.
Yeah. Thank you so very much, Prof. I would like to start with you. I would like to know how many facilities are under Basic Healthcare Provision Fund in Kaduna State. That's 1. Now, I was going to ask a question earlier. We all know what maternal health is, and we all know how it's dealing with all of us, and we are all involved. Now, for Dr. Wada, thank you very much. What are you advocating for Nigerians to have, let's say in the 6 geopolitical zones, to have PPP, just what we have with Garki hospitals? Do you think, I don't know, we just wanted to share your opinions on that. Thank you.
Thank you. Let's take
conversation towards the drivers of PHC delivery, especially in rural areas. Because I noticed we've talked a lot about infrastructure, but then a major driver